morning, everybody. Thank you very much for joining us today. My name is Don Elliman, and I have the honor of being the chancellor of the University of Colorado Anschutz Medical Campus. First, let me express our gratitude to you, those of you in the audience. You are a vital member of a strong community of support that has stepped up to help us advance our efforts in these times. Philanthropic support has been critical to our ability to respond amid the shifting circumstances of this pandemic and to pursue new treatments for those that we serve. I also want to thank our entire campus community, researchers, physicians, and students who've adapted nimbly in the face of this continued change and continue to ensure that we can deliver on our research education and especially, frankly, on our clinical missions. This past year has shown us several phases of the pandemic. It's also shown us the tremendous importance of our mission as a leading academic medical institution. Throughout this year's events, we have risen, I think, again and again to meet the needs of the ever-changing healthcare landscape. And as we experience this new wave or another wave of COVID-19 and across the country, we are very fortunate here on this campus to have talented leaders, several of whom are here with us today. Our panelists, I think, bring a unique perspective to our conversation about where we stand and where we're going, from deepening our understanding of infectious diseases to the latest in clinical trials and vaccine development, to the modeling efforts informing our state's response and the realities of patient care at the front line of the patients for patients throughout the region. So without further ado, let me introduce the panelists. Dr. Michelle Barron. Dr. Barron is a professor of medicine in the Division of Infectious Diseases at the CU School of Medicine. She's also Senior Director of Infection Prevention and Control at UC Health. And Michelle will address updates as to how we've managed the hospitalization of patients, as well as ways to prevent transmission and infection. Dr. Thomas Campbell. Tom is Professor of Medicine, Division of Infectious Diseases at CU School of Medicine with a specialty in clinical trials and of viral infections, including HIV/AIDS and COVID-19. He's the Associate Director of Clinical Research, and he will share strategies for treating COVID-19 and progress, most importantly, that we're making in our vaccine efforts. Dr. Elizabeth Carlton is an Associate Professor in the Department of Public Health and Environment and Occupational Health at the Colorado School of Public Health, which is based here at Anschutz. She will share her expertise with regard to modeling and how our campus has advised policymakers and especially Governor Polis in Colorado. Dr. Thomas Flaig, Vice Chancellor for Research in the University of Anschutz Medical Campus. He's a professor in the Division of Medical Oncology at the CU School of Medicine, and he will talk through the campus research enterprise and how our infrastructure has been applied and adapted to speed the COVID relief efforts. Finally, and certainly not least, is Dr. Adit Ginde, Professor and Vice Chair for Research in the Department of Emergency Medicine at the CU Anschutz Medical Campus, specializing in acute clinical care trials, and he will share how we are contributing to clinical trials and promising COVID-19 therapies, as well as our approach to patient care at the very point of the spear, which is the emergency department. While we have some questions for our panelists, we would also like to hear from you. We have perhaps as many as almost 3,000 people on the webinar today. So if you have questions, please put them in the chat room. I'm afraid we may not, I can virtually guarantee we won't be able to get to all of them, but we'll try to do the best we can when we are through the beginning part of the program. So to our questions, let me start with Dr. Ginde. You are the first line of defense. I mean, you see patients when they first present in the emergency department. Can you talk about what's changed and what's different now from where we were 7 or 8 months ago?
First of all, thank you, Chancellor Elliman, for hosting this forum. It's a really pivotal time in the COVID-19 pandemic. I'm grateful to be here and to work with this group of transcendent leaders at CU Anschutz. The emergency department's been on the front lines of care for COVID-19 patients really since the pandemic began. There's no question right now we're in a very challenging time. In the spring, there was really a lot of uncertainties about many things. We didn't know exactly how to keep ourselves safe, our families safe. patients, and communities. Right now, many months into this pandemic, we're much more confident in how we take care of patients and how we keep ourselves safe. And that's a really good thing. But it doesn't mean that it's easy. We're seeing more patients with COVID-19 than we ever have, even in the spring. At University of Colorado Hospital alone, we're routinely hospitalizing over 20 patients per day from the ER, and fortunately are able to send many dozens of other patients home. But compared to the spring, one of the challenges, in addition to the COVID volume, is that the volume of other patients with other conditions that are not COVID are as high as ever. So in the ER, we see patients that are undifferentiated without diagnoses. And at any moment, any of those patients could actually have COVID given the range of symptoms. So every step in caring for patients takes a little longer. With the hospital being full and patient volumes continuing to rise, it's all a little bit more challenging. And right now, the pandemic's hopefully reaching its final peak. Frontline doctors, nurses, techs, and many others are putting their physical and mental health at risk, at great personal sacrifice to themselves and their families. But in the ER, this is what we're trained to do. I'm really proud of my colleagues who have stepped up in a truly heroic way. And there's really a sense of duty, sacrifice, and purpose that goes into the work that we do as frontline providers every day, 24/7. Right now, it's not easy, but the teamwork and the shared vision that we've seen in the ER and with our colleagues in the inpatient and outpatient settings have truly been remarkable. I'm hopeful over the next few months, we'll get through this together and see better days in the spring and summer.
Thank you. Dr. Barron, can you talk about what the current state of the hospital system is? I mean, what's the census look like today versus where we were last spring? And really address the question of, I think, and you and Dr. Carlton can both speak to this, we're kind of expecting almost with some degree of certainty that the next few weeks are gonna bear fruit, not sour fruit. Can we handle the crush? I mean, are we going to be? What are the prospects of us being overwhelmed? I guess that's really the first question that I have for you.
Okay, so starting with just numbers, if you look at our current census, and it changes literally, I feel like every couple of hours there's a different number. But if you look across the UC Health system, which includes 13 hospitals, we're about 456 individuals are currently hospitalized with a COVID diagnosis. This is significantly higher than what we saw even the peak in the spring, and I thought we had seen a lot at that point. So we're probably almost double what we saw at that time. We are projecting that there are going to continue to be increases in both hospitalizations as well as the number of cases in the community that will result in hospitalization. I think there's a lot of debate as to, and I'll let Dr. Carlton speak to some of the projections, but there's a lot of concern about the current testing. With the Thanksgiving holidays, there's two things you should know about the numbers. One, a lot of the testing centers were closed, and so there's going to be just less testing. And there's also always a lag in reporting. And so there's always a delay in terms of the numbers, and where if you look at them daily, you may think, oh, we're doing much better. But if you really want to look at it, you should probably be looking at the 7-day average. And we expect that because of the delays in reporting and the less testing, for this week, we're going to look better than we have. But we don't, I can certainly say from hospitalization standpoint, we sort of bounce down slightly, but not really. If you look at our overall numbers, we continue to increase. And then just to answer the question, are we ready? I think we have been obviously working on this since March, and we've refined a lot of the things that we've done. There's a lot of cooperation across the state for hospitals to be able to share information regarding their bed capacity, so that we can figure out that if there's one hospital that is getting overrun with patients and doesn't have the ability to care for them, that these patients can then be transferred to a different hospital, hopefully within the same region, but wherever they can go, that they can still get the care that they need without worrying about how are we going to staff this, how are we going to take care for them. So that's been happening on the state level with a high level of cooperation across all the hospital systems. And then I'll let Dr. Carlton talk about the specifics of the projections.
We'll get to that in a second. What's changed in how we're treating those infected today? And is the patient population similar to what we saw in terms of the demographics in the spring? And what's changed in how we're treating them?
Yeah, that's a great question. And that's something that we've obviously been very interested in understanding. So we looked at our demographics and we took 2 time frames to really look to see if we could see the difference. So we went from March 1st to May 30th, which was sort of the initial onslaught of when we had huge number of cases. And then we looked from September 1st to about mid-November, sort of as a comparator, looking at this, if you want to call it our second or even our third surge, depending on how you want to define surges. Population demographics, about the same, believe it or not. When you look at who's getting hospitalized, the proportion of people that are older still is about 50%, and older loosely is defined as over 60, and not out to offend anybody on how we define this. This is just sort of a way to look at this. The rest of the hospitalizations vary in terms of the age, but they're very, very similar. What's really interesting is if you look at our mortality, though. So if you look at the March to May, our mortality at that time at UC Health was 12.5%. If you compare that to our current state from September to November, it's about 6%. So about half the mortality that we're seeing. And it's also reflective in the length of stay, where it was about 11 days in March to May, down to about 6 days. So what's different? We do a lot of things very differently. Some of them are obviously some of the medications and treatments, but a lot of it is the upfront treatment that we're doing that we know how to do better. Even simple things of having people that are having difficulty breathing, having them lie on their bellies to increase their oxygenation seems to improve outcomes. And those are just some of the little things that we've learned in terms of how aggressive we need to be with these individuals, putting them on high flow oxygen. And again, it's really amazing how in very short period of time, we've been able to have that much of an impact.
We've heard a bit about these new monoclonal antibodies from Lilly and I guess now Regeneron. And I've also heard that they appear to be very effective on certain patients, certain types of patients. But I've also heard they're in relatively short supply. Do we have access to them, and is the supply increasing? I mean, is that something to really, on the therapeutic side, to be hopeful about?
I think that, again, they are in short supply, but they are available, and they're available across the state. There is very specific criteria for the individuals who should potentially want to have access to this particular drug. I can never say this correctly, benlamivibab, I just probably massacred that one, is being allocated by the state through a randomization, so that there's probably going to be more people that potentially will qualify for this drug than is actually available. And so in an effort to be equitable and fair, if you meet the criteria, your physician enters you into this random allocation, and then they tell you, yes, you can potentially have access to the drug, and then it directs you to where you can potentially have the drug. And this process will continue with the new, like Regeneron and others, I know is being evaluated across the state, again, in an effort to have access to this.
Thank you. Dr. Flaig, Tom, we've been involved in a host of clinical trials on the therapy side. Can you talk about how they move forward, both with industry partners and with our own faculty?
To do so, and just really glad to be part of this panel and having this discussion today. So I think CU Anschutz, we are fortunate to have a research enterprise at baseline, which we could then adapt and respond to this pandemic in meaningful and powerful ways. And I would say that our laboratory research colleagues in the labs have made significant change. Many people who are working in laboratories. So again, we have over 500 biomedical research laboratories. So think of people in white lab coats at lab benches doing work every day, thousands of people in the normal setting, who pivoted and said, how can we contribute to this pandemic? And we had fundamental scientific discoveries of this virus and how it works and what its vulnerabilities might be. Other researchers found serologic tests that could be used to assess patients to see if they've been exposed. So we had that wonderful work going on. Clinical trials, there's been a lot of focus on clinical trials. I think in my time in medicine, I've never seen so much interest in media play. So I think a lot of us have learned how trials work. This is the way we take therapies or vaccines, we evaluate them. There's an existing system which we've applied to COVID. We look at safety, we looked at efficacy, and I would say there's kind of two major categories. And again, at baseline, we have over 2,000 clinical trials open on our campus and with our affiliates. So we have a robust infrastructure at baseline. We've now applied that to COVID-19, but one major group of trials we've done are therapies. So Dr. Barron just mentioned a few. I think Dr. Ginde and Campbell can also talk about these, but these are treatments for people that have the disease, that have the symptoms. So think of how we use antibiotics again for pneumonia. We're using antivirals, anti-inflammatories, other monoclonals to treat those that have the disease. We've made significant contributions, and again, I think Dr. Ginde can talk about that a bit further. The other major bucket is that of prevention of vaccines. And again, we've all been listening to the 30,000 patient study, the endpoint, the safety. We've all learned a lot about clinical trials, and we've been able to apply what we've been doing here for many years to COVID-19. Dr. Campbell has led our effort here locally with Moderna. We're very proud of the contributions we've made. So I think for all of us listening, we've learned about how this process works. We're very grateful for the people that have participated in these clinical trials and the leadership of our people. And I would just say it's been heartwarming to see the research community adapt, respond, work tremendous hours, and find ways in which we can contribute.
Dr. Ginde, as Tom said, you've been a part of this. How have healthcare providers and patients responded to being asked if they want to enroll in a clinic? I mean, how has it worked? You're muted.
Thanks. It's been a really remarkable experience over the last 9 months being involved with this. We've really been at the forefront of therapeutic clinical trials, as Dr. Flaig said at CU Anschutz, provided access to remdesivir, monoclonal antibodies, convalescent plasma, a number of other promising treatments well before they were broadly available. So really being part of the solution. Luckily, our culture, even before COVID, was to think about patient care in terms of taking care of the patient in front of us, but also at the same time discovering new therapies and new ways of taking care of patients. And so this embedding of the culture of discovery and of innovation really laid the groundwork for doing this sort of research when the time came. And we didn't really have to install new processes. We didn't have to convince providers to participate or describe how important it was. There's really been a broad support from leadership down to frontline providers. And they're really expecting it. We didn't deliver on this. I think people would have been disappointed. And so the enthusiasm and pride amongst the providers has been very high to participate in these transformational clinical trials. And this sort of low friction environment for research has made it as easy as possible, I think, for the bedside providers to participate and make their mark. As you mentioned, the other part of this is the patient and the family. Dr. Flaig touched on this as well. Patients and families are scared when they come in with COVID diagnoses or COVID symptoms. Really, despite their fear of the illness, they've been proud to volunteer for clinical trials, partially to access cutting edge treatments, but also to be part of the solution for future patients. I've had personally the pleasure of enrolling dozens of patients into these trials, and it's really clear and remarkable that the desire to help others through their participation in trials has been so resounding. And so there's this great spirit of altruism out there in the community. I think it's really a cause for optimism of what we're trying to accomplish.
Thanks. Michelle, we are approaching the flu season, if we're not already in it, which is going to present a double whammy to this experience that we're having right now. Can you talk about or what we know, if anything, about the onset of the flu season and how that's going to complicate matters?
Sure. So I think that's the big question mark, and certainly one of grave concern to me in terms of numbers. In a typical flu season, we see hundreds of individuals hospitalized with complications related to influenza. And so it's been one of those things where we've been anxiously awaiting to see what happens. The good news is that so far we have had limited amount of flu activity in the United States, specifically in Colorado. There's only been 11 hospitalizations related to influenza. However, the little asterisk to this is that can change very rapidly. flu season is very variable. Some years it's early, we see it before Thanksgiving. Some years we don't actually see it till late December, early January, and then we'll peak in the spring. So I think we've obviously been pushing very hard for individuals to get their flu shots, get them. If you still haven't gotten your flu shot, it is still not too late to get a flu shot. And I think it's still kind of a watch and wait approach in terms of looking at it. There were evidence of co-infections that occurred in the spring. They were not a high rate, but so much of the testing was just COVID testing that I don't know if we have a complete view of how much flu really was interacting in the setting of COVID as well. So I think the good thing or good news is that a lot of the things that we do to prevent COVID are also things we can prevent flu. So washing hands, wearing masks, cleaning surfaces, and social distancing are all measures in addition to the influenza vaccine that will be very helpful. And I just really hope we don't have a big flu uprise as well, but I can't say that we won't.
Dr. Carlton, you have been at the pointy end of the modeling spear, advising CDPHE and Governor Polis with how the state should be acting on its response. I know it's a difficult task or a difficult question to answer, but where do you see this headed across the state right now? What's the latest on that?
Thanks for the question, and thanks for the opportunity to be here today. I think to answer that question, it's worth spending a minute on where we are now. And as has been mentioned, there are twice as many people in the hospital with COVID-19 in Colorado than there were at the peak we experienced in April. And we think there are more people infected and infectious with COVID right now than any point in the history of Colorado. So we think that contacts right now are extremely risky and that we're in this period of extended growth since about mid-September. So the modeling team led by Dr. John Samet and including epidemiologists and biostatisticians and mathematicians, economists, social scientists, a big group of us from our campus as well as Denver and Boulder are working closely with the state health officials to try to answer exactly that question. Where are we headed and what may happen next? And I think the answer to that question is tangled up in the collision of two forces. On one hand, there's been some big shifts in policy in Colorado over the last month in an effort to reduce the spread of the virus, and people's risk perception has changed. I think people are increasingly aware of how severe the situation is. All of that could act to slow the spread of infections. On the other hand, we just had Thanksgiving, which if you think about the Norman Rockwell painting of Thanksgiving dinner, that is just the ideal SARS-CoV-2 transmission environment, sadly. It has intergenerational mixing, it has people close together indoors without masks. Looking at the mobility data, it looks like people did move around for the holidays, although perhaps not quite as much as in past years. So to think about those two forces, you can think about the policy piece could be acting to slow the growth of infections, or even better, to reduce the spread of infections. And that could have us either seeing a decline in hospitalizations over the coming weeks, or a slowing growth of hospitalizations. But Thanksgiving could act to increase the spread. So my long-winded answer to your question is I think we may be on a roller coaster for the weeks ahead, in that next week and this week we may see indications of those policy and behavior changes, but because it takes about 2 weeks to see the impact of Thanksgiving, right behind that could be another uptick. I think December is going to be one of the most challenging months that we have in this pandemic, and I imagine Dr. Ginde and Dr. Barron and others would probably agree based on their clinical experience.
Thank you, I think. Dr. Campbell, I laughingly say that you represent the first light at the end of the tunnel that isn't an oncoming train in terms of your work with vaccines. I know that you ran the Moderna trial here at Anschutz. Can you talk to us about vaccines and really the sort of multiple questions of how efficacious are they? How do you define efficacy? Do we know if the effect is durable, and if so, for how long? And is it safe? I mean, that's really the one that's hitting a lot of people in the various different kinds of vaccines. And then I think finally, it appears that we're all going to have choices at some point on which vaccine we take. How will we make those decisions? I mean, so over to you on the broad subject of vaccines.
Great. How much time do I have? An hour?
Yeah.
Humans have been the subject of pandemics for centuries. And in the last 100 years or so, vaccines have been a tool that have helped us control and in some cases eliminate those pandemics and those pathogens. Vaccines simply are a way to train our body's immune system to recognize and attack pathogens like viruses. And in some cases, vaccines have been very, very effective. Smallpox is an example where through vaccinations and public health measures, we were able to eliminate smallpox from the face of the earth. Other diseases that used to have a big toll in the United States, such as yellow fever, measles, chickenpox, we now have very effective vaccines that prevent those from reaching epidemic or pandemic proportions. So coronaviruses, SARS-CoV-2 is not the first coronavirus to make its way into humans. There are 4 other coronaviruses that regularly infect us. In fact, 90% of us will have been infected by all 4 of them by the time we reach adulthood. But they don't cause pandemics. They don't usually put people in the hospital unless it's under certain circumstances, special circumstances. And the reason is that we have good immunity to those other coronaviruses across the human population. And so the hope is with an effective SARS-CoV-2 vaccine that we'll be able to convert SARS-CoV-2 to behave like these other endemic human coronaviruses behave and make SARS-CoV-2 nothing more than a mild respiratory infection for the vast majority of people who contract it, and keep people out of the hospitals, reduce the burden on our healthcare system, and keep people from dying. So in terms of how we go about seeing if vaccines are efficacious, the answer to that is we conduct clinical trials. And Adit and Tom have already discussed some things about clinical trials. And so there are clinical trials that are ongoing for coronavirus, SARS-CoV-2 coronavirus vaccines in the US. There are 4 that are actively ongoing and 2 more that will begin enrolling patients hopefully before the end of the year. So we'll have 6 in total, representing 3 different vaccine technologies. And in these clinical trials, which I should say clinical trials are very well-controlled, tightly designed experiments where efficacy is determined. And efficacy is measured in terms of reduction in disease relative to a placebo. So these clinical trials are all placebo-controlled, randomized, and blinded, and we can compare what happens to people who get the vaccine to what happens to people who get the placebo. And in the case of the SARS-CoV-2 vaccines, we have some early results on efficacy for both the Moderna and the Pfizer vaccines that are very encouraging. So both of these vaccines in early results have 94 to 95% efficacy, which puts them in the highest category of effective vaccines, like things that I mentioned, vaccines for measles, for instance. So this is very, very encouraging. Now, an important point to make there about efficacy of these vaccines is they're being measured in terms of how much they can reduce the risk of getting symptomatic COVID-19 illness. So we don't know yet if these vaccines will actually reduce infection, reduce transmission, but we do know that they reduce illness. And that's very important because, as Adit and Michelle have mentioned, the current state of the pandemic is creating an enormous burden on our healthcare system and leading to death in many patients.
What about durability? Do we have is there any way to guess yet about how long these vaccines are likely to have effect?
We don't know durability yet because we're still very early on. We do know that the vaccines induce high levels of antibodies against the SARS-CoV-2 virus. And we know that those antibodies do decline slightly over the first 4 months or so. But we don't know yet what happens to protection. And I would say that although that is something that we need to continue to study and determine durability, I don't view that as being a Achilles heel of these vaccines by any means, because like for other vaccines, we can always give a booster at a later time if immunity declines.
And how about safety? I mean, the Moderna and the Pfizer trials are vaccines are both mRNA, messenger RNA based technology, which is, I understand it, has never been used in a vaccine before. Are we concerned about the long-term safety effects of these therapies?
So you're absolutely correct. Both of these vaccines are a new platform for vaccines in terms of being mRNA based. Now I say new in that it's relatively new, but actually this technology has been tested since the early 2000s. So we have about 15 years of experience, and these vaccines using the mRNA platform have been developed for other illnesses such as influenza, Zika, Ebola. And so they have been evaluated over longer periods of time, and the platform itself, the mRNA platform, has not had any safety concerns arise. But you are correct, we do need to study safety. From what we know so far from the data that have been released from Pfizer and Moderna, the short-term safety appears to be very good for both of these vaccines. The trials that are evaluating them will continue to go on. They're planned for 2 years. And over those periods of time, we'll get more information on the longer-term safety. But I'd have to say that based on what we know about other vaccines, the vast majority of safety problems arise within the first few months after vaccination, and long-term safety issues are not very common.
Okay, now for the $64,000 question. When can I get mine? I mean, and I'll start with you, Tom, but open it up to anybody. If let's take a hypothetical case of a 60-year-old female, maybe with mild comorbidity. What's your guess on when a vaccine is going to be available for somebody like that?
Yeah, so we do know that pending FDA authorization for emergency use, that the Pfizer vaccine will start to be distributed in the next couple of weeks. We know that the plan is that it will first be used for high-risk healthcare workers, as well as individuals who live in institutionalized settings, such as nursing homes, that puts them at high risk for exposure to SARS-CoV-2. But as more vaccines become available, and we hope that Moderna will also then get a emergency use authorization, it's about a week behind the schedule from Pfizer, so that by the end of the year, we should have a distribution of both of those vaccines going in a very large scale. So in answer to your question, I think someone who has comorbidities that put them at risk for having severe COVID-19 illness will likely have access to one of those vaccines by, I would say, February sometime.
Michelle, do you share that optimism?
Yes, I like to have optimism. It's necessary thing in this time. I think obviously the key part is having access to adequate supplies. I think all the health systems, again, in Colorado have been working in conjunction with the health department as well as with each other to make sure that we're doing things in a similar fashion, that we're going to prioritize based on the standards that have been given to us. And so I think everybody's ready and waiting to put this into action. And just, I would ask, as the general population as well as our healthcare workers, that a level of patience in that the initial distribution is probably not going to be what we want, and that we want it all right now. And it's just going to take some time. But I think once we have them, the more that we have, the better in terms of being able to allow more access for that. The prioritization is going to be in phases in terms of making sure those that are most vulnerable or most at risk are getting access from the get-go. And then we have to remember there's 2 shots for several of these vaccines. And so that's, from a logistics and operations piece, not something that's impossible to overcome, but it's an important piece that when it starts becoming available more broadly, that you need to remember that once you get your first shot, you're not done. You're going to have to still get that second shot until we hear otherwise. And that does not give you permission to not still follow the rules as far as masking, hand hygiene, and distancing, because they're probably, just like flu shot, we know takes about 2 weeks to be completely effective. There's probably going to be a duration of time in which we need you to wait to be sure it's working before we can suspend our normal rules.
Thank you. Okay, Michelle, let me end the sort of prepared portion of the program with a question for you. While we wait for these vaccines, what are the best ways to prevent COVID-19 and transmission and infection? And I mean, really, how should we be acting now, I guess? And what would you say about one question that came up on the chat was, can I ski this holiday season? How would you suggest we look at the next 3 or 4 weeks in terms of personal behavior?
Sure. So the basics still apply. So wearing masks when you're out and about, making sure you're washing your hands, trying to avoid large gatherings and keeping it within your social bubbles or your family bubbles is still really important. I'm very pragmatic in terms of thinking through things, and that the reality and what we say and some of the realities aren't always so clear cut. And so the key in terms of what about my personal decisions, whether I want to go skiing, maybe I want to visit family members, or I have circumstances that just aren't going to fit into the rules of stay home and don't do anything outside of those circles. So I think the key things is the basics are important. And then I tell everyone, do a risk assessment. Assess your own personal risk in terms of what are my underlying health issues? What are my underlying risks in terms of if I acquired COVID-19, what would that look like? And would I have to be off work? And can I afford to do that kind of thing? And then what's the activity that I'm planning on doing? Am I going to see my elderly mother? Can I mitigate that? She would potentially be high risk. Could I mitigate that by quarantining for 14 days before seeing her and not getting on a plane necessarily? There's a lot of variables. There's a lot of thought that you need to put into that, who you're going to see and what you're going to do. In terms of the question about skiing, the skiing part is outdoors. For the most part, you have good air currents. Most of us have coverings over our face because it's cold. And so it's not a zero risk, but it's probably lesser risk than having 15 people in your living room that you don't normally associate with, and none of you are wearing masks. So I think, again, this is one of those questions. Certainly from the skiing standpoint, my biggest worry isn't the skiing part, because again, you're outdoors, you're usually moving through on the slopes. It's the after skiing that gets us into trouble. So it's going to the bars, getting in the hot tubs. Those are things that are going to probably increase your risk. I'm not saying you cannot do them, but it's probably not a good idea if you're really trying to mitigate your risk.
We've heard 2 terms today, COVID-19 and SARS-CoV-2. And one question is, what's the difference? I think the difference is there is no difference. They're the same thing. Am I right about that?
Well, there is a subtle difference. So SARS-CoV-2 is the virus. So it's the virus that causes the illness. The illness that is caused by SARS-CoV-2 is called COVID-19.
Thank you. Appreciate that. What, if any, this is to anybody, what, if any, might the positives of the UK getting a jump on vaccine distribution, is that a good thing for us? I mean, we'll have somebody out there ahead of us. Is that helpful in any way?
I don't think it's going to make any difference. They're at the most they're a week or two ahead of us, and in the scheme of things, we're talking about a process that's going to take 6 months to a year to get vaccines across the whole population. And so a 1 to 2 week head start doesn't make a difference as far as I can tell.
Are we expecting that there, I'm now back to, I'm taking questions from the chat room. Is there any danger of an overactive immune response to those who have the antibodies or a sensitized immune system? Do we have any information on that?
Yeah, that's a very good question. There is a phenomenon where that does happen, and it does happen in some other infectious diseases and with some other vaccines. And so there has been concern about that with SARS-CoV-2 and the COVID-19 vaccines. And in testing in animals and in early testing in humans, that has not been observed. The type of immune response that is associated with that we call a Th2 response has not been observed with these vaccines. And in the clinical trials so far, worsened COVID-19 illness among the vaccinees has not been observed. And in fact, the opposite has been found. People who get the vaccine have much less illness, and when they do get sick, it's of much less severity.
There was actually something on the news this morning about several hundred Coloradans appear to have been infected now twice by COVID. Can somebody speak to whether we see that as a threat and coming down the pike?
So in terms of vaccines, I think that that is not going to be unexpected. I mentioned the other 4 endemic coronaviruses that have been with us for thousands of years. We get infected with those multiple times over our lifetime. And as I mentioned earlier, we don't know if these vaccines will actually prevent infection. But what we do know is they prevent illness. And so as long as we're preventing illness, people aren't getting sick, people aren't dying, people aren't clogging up the hospitals, then it doesn't matter if we get infected multiple times as long as those infections are mild.
So would that suggest that people who've had COVID still should get the vaccine?
Absolutely, and that is that's what I anticipate the recommendation will be.
And I'll just add, from the frontline perspective, we've definitely seen return visits over a few month period with recurrent COVID. It's not always mild, but it seems to be more mild. And so I think I would echo the experience that Tom Campbell has had from the vaccine perspective, that it still occurs, it's still worth getting the vaccine. It's not common, but it does happen.
One question is, which vaccine will be offered by UC Health, Moderna or Pfizer, or ABC, all of the above?
All the above once they're available. We're actually open and ready to get whatever we can receive, but obviously whatever comes first is what we'll start moving, and then we'll just continue the process. And there was a question regarding when is the second dose required? I believe for Pfizer it's 21 days, for Moderna it's 28 days. Some of the newer vaccines coming through have slightly different time schedules, but we'll make an account of that when the vaccine distribution starts.
What's the latest information on long-term COVID? And in terms of, we know that there are people, I guess they call them long haulers. Is there any improvement on our ability to treat them, and do we see any hope in that arena?
I'll start. We've done some epidemiologic work with the CDC on longer term symptoms. It's clear that a certain proportion, maybe a quarter or a third, will have symptoms that last beyond several weeks, and then a number that will have symptoms for many months. I've seen some of the comments in the chat from people that have experienced such a symptom. I don't think we know that much about that. There was just an NIH panel yesterday, actually, to try to address research that could study and impacted interventions that could modify those long-term symptoms. We're trying to start to incorporate those into our therapeutic clinical trials. Hopefully the vaccine will also, in reducing the severity of any illness that occurs, will hopefully reduce the duration of symptoms. But I think these are great questions, and I think still some unknowns, but very important.
One question with a very specific indication is, have there been vaccine trials for cancer patients?
So the vaccine trials so far did not exclude cancer patients as long as they had stable illness and were not immunosuppressed. So to some extent, there may have been cancer patient representation in the trials that are ongoing. These trials have excluded people with immunosuppression. We don't know yet whether the vaccine will work in those groups. We don't have any reason to think that it would not be safe in those groups. So I think that we'll have to study efficacy in these immunosuppressed patients as the vaccines become available.
I know there's been an awful lot of discussion on the subject, but there's a question from the audience. If someone is asymptomatic but carrying COVID, how long can they carry it and spread it to others? Michelle?
Sure. Don could answer this probably too. So that's actually been a great question, and it's something that's been looked at now under a lot of different instances. And so again, this is sort of the law of averages. And so one thing to be very clear is that having a positive PCR test does not necessarily equate to infectivity. PCR detects the virus, but doesn't really tell you whether there's enough of the virus to transmit to other people. So based on several studies that have come out recently, it looks like the first 48 hours after infection has started, where you may be asymptomatic at this time or the whole time, that's when you're probably the most infectious, and that makes sense to us in terms of a lot of viruses. That initial onset is when the virus factory, so to speak, is really upticking, and so there's lots of virus there. If you're not immunocompromised and you don't have severe disease, it's about 10 days is the time frame in which individuals are still considered infectious. And this is based on studies that looked at the actual virus being isolated from PCR and then putting it into cultures to see if it could kill cells, which is the best we can do in terms of looking at a transmission model. If you're immunocompromised or you have severe disease that requires hospitalization, it's 20 days is considered the infectious period. There is some data in transplant patients, specifically hematologic malignancy patients or stem cell transplants, that suggest that some people can even continue to spread virus beyond that 20-day period, but there's still not enough data yet to really tell us what is the threshold that you can say, okay, if I'm a transplant patient, that this is the cutoff from that time frame. And the CDC has now adjusted some of its guidance in terms of that quarantine period and isolation period, and they're slightly different. So just for clarity, if you have a known diagnosis of COVID-19 and you are asymptomatic, you go into isolation, and that's 10 days. The change is to quarantine. So quarantine is when I have COVID-19 and the person I live with is not symptomatic and has not had symptoms or has not tested positive, but is being exposed to me. And so that quarantine period, so that person would go into quarantine. And that has shifted from 14 days to 10 days, or potentially down to 7 days if you get testing, and if the testing is negative and you have no symptoms.
In the early wave through the spring, we saw an awful lot of people avoid going to the hospital. because they were scared. Clearly, that had some negative implications on their health long term. Do you have advice today for people who maybe see a new mole or have suddenly some symptom that would normally cause them to go visit either a clinic or the emergency room, but are trying to avoid it for the simple reason they're worried about getting infected? Do you have thoughts on that? Either Adit, I guess, or Michelle?
I can maybe start from the acute care perspective. You're absolutely right. In the spring, it was remarkable. There was about a 40% decrease in overall volume that was coming to the ER, despite the increase in COVID volumes. So people were clearly delaying care, delaying acute care. We were seeing some pretty advanced and troubling presentations of serious illnesses, stroke, heart attacks, and the like. And so I think now people feel more comfortable seeking care, but there still is that concern out there. I've seen a couple of questions in the chat about that. So certainly from the acute care perspective, if you need to seek care like you normally would, please do. We are taking every precaution in the ER, in the hospital setting, in the clinics to keep people safe, to make sure the appropriate environmental precautions are in place and patients are safe. We're not seeing transmission because of healthcare visits. And so I think the message for the community is seek care, and there's other options. If you're worried about going out there, there's a huge expansion in telehealth, both for primary care, specialty care, acute care, and that's been a major advance, which I think is here to stay. Every crisis provides an opportunity, and the opportunity is that we've expanded our capabilities, and that's going to keep going.
Oh, there was a question. Go ahead, Michelle.
I was going to say, just reiterate that we have a lot of safety controls in the clinics, in the hospitals for procedures. There's testing that happens. There's symptom monitoring. Everybody's required to wear masks. I think the environment is very safe. Obviously, if you don't feel safe coming in, utilizing the other options, but we do not want people to delay their care, especially for health maintenance wise. Like, this is my plug for vaccines again. We really don't want to end up with a measles outbreak or some other kind of vaccine preventable disease because those normal visits for kids or for others aren't happening. So I think it can be done safely. We have all these checks and balances, and so don't delay.
Don't delay. Kind of like wear the mask, sort of along the same line. We had 3 specific questions: people with lupus, people with diabetes, and people with MS. Would they be candidates for the vaccine, or should they be candidates for the vaccine?
So those individuals were not excluded from participating in the vaccine trials. And matter of fact, those types of individuals with ongoing medical conditions were actively recruited into the trials as long as they were not on any prohibited immunosuppressive therapy. So for instance, if you had lupus, but you were having a flare that required high dose treatment with corticosteroids, that type of individual would not have been eligible to enter. But certainly diabetics, there were a lot of diabetics who participated in the trials. We know that the vaccine is safe and works well for diabetics.
Should pregnant women receive the vaccine?
That we don't know yet, and pregnant women were excluded from participating. And I think that is an area that will need further study.
The governor encouraged Coloradans to get the COVID exposure app on your mobile phone. I did, but are those data going to be useful for modeling conducted by CDPHE? Dr. Carlton, I mean, is that a helpful tool?
So what we know is that the people who are, as Dr. Barron said, the people who are infected and infectious and are most infectious before they show symptoms. So the whole idea of contact tracing is if we can identify the contacts of people who are infected, we can get to them before they start showing symptoms and ask them to isolate. So from a transmission control perspective, this app is extremely useful because it can help you know that you may have been exposed and ask you to stay home at a period when it may be very risky for you to interact with older adults, loved ones, et cetera. We don't actually have access to the data on that platform, I think for privacy reasons. And I think that privacy is a real priority in using that app, but rather it's a tool to let people know they potentially been exposed and to protect the people in their contact networks.
Thank you. What are the current criteria for when to hospitalize a patient? When do you say thanks and go home, or monitor, or when do you say, you know what, you need to come in now?
I can start with that. This is sort of our day-to-day in the emergency department of making these decisions. I would say that it's evolved over time like everything else, but basically it is requiring oxygen support. Typically the people that get hospitalized require supplemental oxygen, have pneumonia, or have some sort of other organ injury, kidney injury, some sort of myocardial or heart injury. So people that are hospitalized are pretty sick. There are high-risk patients that we are able to send home. We're actually even able to send patients home on supplemental oxygen and arrange for that from the emergency department if it's a low amount and they're otherwise doing well. So many patients are being able to be managed on an outpatient basis, but it's really those that have progressive, more severe disease and are at high risk for getting worse, and that we can initiate therapies in the hospital setting.
People who've recently been vaccinated for whether it's flu or shingles or whatever, obviously those people should consider themselves still as candidates for any vaccine when it comes out. Am I correct in that?
That is correct. The trials that have been done so far have allowed people who have had recent vaccination with flu and other things, as long as it's not too close to the date of the COVID vaccine.
Got it. Okay. Unfortunately, I think we've reached the end of our allotted time, and I want to extend my thanks to the panelists. You all have been great, and I really appreciate your taking the time from what is clearly a busy schedule to do this. We're very grateful for that. As I think you can imagine, we've had more great questions than we could get to today, and we would encourage you to visit the CU Anschutz newsroom at news.cuanschutz.edu for the latest information on our campus response. We will circulate a link along with a recording of today's panel as a follow-up to everybody who registered. So on behalf of the University of Colorado and myself, for sure, be well, be safe, and thank you all for doing what you're doing to help us be strong. We appreciate it. Have a great day, everybody.
Bye-bye. Thank you very much.